Right. Good afternoon, good evening, and good morning, and welcome to this second session for today on COVID-19 and HIV, lessons learned from frontline healthcare workers around the world. My name is Lucy Stackpole-Moore, and I'm the Director of HIV Programs and Advocacy with the International AIDS Society, and I'm thrilled to be chairing this webinar today, and we have a terrific panel and some really interesting insights ahead today. The aim for the webinar and the whole series, but also for today in particular, is to celebrate the pioneering work of healthcare providers, researchers, and communities around the world in the response to COVID-19, many of whom are IAS members. And we're also keen to provide an opportunity for discussion on the pandemic and also have a deeper look at how it impacts people living with HIV and aspects of access to health services. Before we get started, I'd like to introduce a couple of housekeeping rules for the webinar. Please note, given the large number of attendees, all participants are muted, but please do feel free to send questions at any time throughout the webinar. You see at the bottom of your screen, there's two boxes, one called Q&A for question and answer. That's where you should post questions to the panel in relation to any of the content you're hearing in the webinar. In the box called chats, that's where you should post any issues you are having technically in terms of hearing speakers or viewing the slides. Please note that at the end of the webinar, we will have around 30 minutes for question and answers, and we appreciate that all of the speakers are going to remain online to respond to as many of those questions as possible. You can also email questions to an email address, which is coronaquestions@iasociety.org. And just to mention that the session today is being recorded and will be available on the IAS COVID-19 portal, hopefully from tomorrow, where you can also view and listen to the previous webinars in the series as well. So without further ado, I'd like to welcome our distinguished moderator for today's sessions, Dr. Shanine Hayder, who is the Assistant Secretary General and Deputy Executive Director of UNAIDS. Dr. Hayder brings to the position more than 20 years of international experience in global health, from HIV and infectious diseases right through to strengthening health systems. She holds a degree in biological sciences from Stanford University and an MD and an MPH from Columbia University. Dr. Hayder is board certified in internal medicine, pediatrics, and infectious diseases. And she has served in key health leadership roles, emphasizing accountability, scale, and the impacts for sustainable responses. So we're really honored that Dr. Hayder has enabled herself to be with us today and share her time and her insights with such a terrific panel. Over to you, Dr. Hayder.
Great, thank you so much. First, I just want to start by thanking IAS. I am a proud IAS member, and I'm really so grateful to be here with all of you today. I want to extend my thanks to the hundreds of people on the call who have taken time out of their busy schedules, out of your busy schedules today to come to this forum. And especially I want to thank the presenters who have really lined up to do, I think, what IAS does best, which is not only demonstrate the commitment to mission and to people that our members and these experts demonstrate every day, but also this commitment to sharing our knowledge in real time and making each other smarter because of it. As I read through in preparation the presenters and their experiences that they were going to share, we are really hearing from everybody who is defining the way forward through their experiences at the front lines in real time. So thank you all in advance. With that, we are going to get right to the presentations. Our first presenter is Dr. Esteban Portello, who is Deputy Director of Clinical Services from the Evandro Chagas National Institute of Infectious Diseases from Fundação Oswaldo Cruz, otherwise known as Fiocruz in Brazil. So for lessons from the response in Brazil, over to you, Dr. Esteban.
Hello, everybody. I'd like to thank IAS for this opportunity to share with my colleagues all over the world our experiences regarding COVID-19 and specifically issues related to HIV infected patients. So next, please. We have now, these are data from yesterday. We are now have more than 40,000 cases, confirmed cases of COVID-19 in Brazil, and it should have said that this is probably grossly underestimated, because we just make tests in hospitalized patients, because the tests are still on short supply, like most areas in the world. We are approaching as well 3,000 deaths right now. Next, please. More importantly, it should have noted that we are still on an ascending line of the total cases, and we are expecting hard times for the next 2 weeks, because our health system, specifically our public health system, are still on the border of being overburdened. And we still, in Brazil, we work roughly with 90% of occupations of ICU beds. So we were not, obviously not prepared to face this challenge, again, like most areas in the world. So we are in a kind of hurry between our capacity to spend our ICU bed facilities and the numbers of this epidemic. Of course, Brazil is a huge country, so we have differences regarding geographic, social, and economic aspects in the over the regions. We have São Paulo was the first state to witness the rising number of cases and deaths, but São Paulo is also the wealthiest state as well. So it's a state that has more resources. We have on the other side, Amazon state on the north that is already overburdened with their health capacities, still stressing with the number of cases. We have the northeast area is also beating very hard right now. And we are afraid of what would happen in the south of the country, because it usually suffer with winter seasons of flus, and we are approaching the time when the temperatures all over Brazil will get lower. Next, please. The number of total deaths is also on a rise. As we see in this graphic, and of course it leads to suffering and fears and all the things that usually follows those deaths, and it's also some kind of unsafety feelings, because we have some also political noise. We have just replaced our Minister of Health in Brazil, because some discussions related to the president's vision of the social distancing measures, because he made some statements against this social distancing. But we know that most of our populations are in favor of those social measure distance. But this public noise could jeopardize our capacity to react to the epidemic. Next, please. So what about HIV? We have a huge program of HIV. We are dealing with HIV the next decade, or the last decades, and we're seeing that our numbers are doing pretty well. We have kind of 80% of patients in 2019 that are adequately suppressed, viral load suppression, but we have also 10 to 20% of patients that are not very well suppressed, and roughly 10% of patients that are lost to follow-up. Next, please. Together with a number of cases that are late presenters that are decaying in the last decade also, but it's stable right now around 20 to 30%. So we have a huge number of patients that are vulnerable to HIV-related infections and HIV respiratory infections like PCP, like TB. And we are afraid, but because those kind of infections may not be very well distinguished from, very well discerned from the COVID-19 cases. So maybe some treatable infectious disease like PCP or TB may not be adequately treated because there will be this misleading problem regarding the COVID-19 cases. So we are very afraid of this kind of situation, even with our high numbers of suppression patients. Next, please. So what kind of weapons we have to deal with this challenge? We have unified health systems that very well structured, but it's of course, as we live on a restrained resource area, we have problems related resources. We have problems regarding the money and the health professionals and so on. So we have it's now time to strengthen this kind of this healthcare system because we'll need it desperately to deal with the epidemic. Next, please. We also have a very good experience regarding research and regarding clinical trials, and we are now working with our health minister and with WHO, with the Solidarity Study. There are many clinical trials in Brazil regarding the COVID-19 treatment, but we are specifically dealing with the Solidarity Study that will follow 4 types of intervention, 4 types of treatment, including lopinavir-ritonavir, that was a medication that was usually used to treat HIV-infected patients, together with interferon, and we will also test as well remdesivir and chloroquine. So we are expecting to include a huge number of patients pretty soon, and then we can maybe give some answers to the society and to Brazilian society and to people all over the world regarding the best way to deal with treatment of hospitalized patients. So that's what I would like to say to you. Thank you very much for your attention. Thank you very much.
Thank you. Sorry, trying to reach my unmute, and I did that not in a great way. Thank you so much for those fantastic lessons. And I think both what you're doing with COVID and while also I think highlighting that in an incredibly successful national HIV program, this issue of late presenters persists. And so even as we think about COVID, how do we think about the future for HIV response as well? Next, I'd like to move us to lessons learned from the Dominican Republic. We have the pleasure to have Dr. Robert Paulino Ramirez, who is the director of the Instituto de Medicina Tropical y Salud Global from the Universidad Iberoamericana in the Dominican Republic. So over to you, Dr. Paulino Ramirez. Thank you.
Thank you so much. And thank you everyone for being here today in this new methodology of having meetings that COVID has forced everyone everywhere. And I really want to give you a welcome to everyone that is from many countries joining us. Well, what we have so far in the Dominican Republic, can you please continue the next one? So we have our first COVID-19 case confirmed in February 29th. It was previously discussed the introduction of the virus in the country, but it was finally confirmed on that date. Confluencing with many political situations after an election crisis that was succeeding even just before that date. In March 16, we have a national municipal elections, and just before that, it was the first case of mortality that was associated actually to HIV and tuberculosis. So far until now, we have approximately 5,000 cases. The government declared in March 19 a national emergency declaration and forcing a lockdown, a national lockdown from during the night time, from 6 p.m., 5 p.m. until 6 a.m. in the morning. That was actually making many arguments about how earlier was that decision or how late was that decision taken, but that was the final decision of the governmental, and it was universally put it in place in the country. Then in April 14, it was extended for until the end of April, and we are seeing right now, approximately roughly 200 and something cases, 53 cases of confirmed deaths related to COVID-19. Next, please. So what we have with these two pandemics conflicting in the country, the Caribbean is, historically speaking, the second mostly affected region in the world by HIV/AIDS. We have historical experiences in the fight of HIV/AIDS, but there was actually bringing, COVID-19 was bringing a new discussion and a new challenge for those living with HIV, because the first death in the country was correlated to HIV, was producing a very high increase of fear in among them. The first case that was reported was a female in antiretroviral therapy, but having also other comorbidities. The second case that was linked to HIV as well was also a female with an HIV test that was performed after having the COVID-19 diagnosis and having also diabetes. In the first case, it was a male of 61 years old that was actually in antiretroviral therapy, but was lost in follow-up, and we don't know any comorbidities regarding them. One of the biggest challenges that we have so far with the National Registry of Mortality is that there is no segregation within the comorbidities, and also trying to identify if among those that are positive, how many of them are actually having HIV as well. But it was some one of the elements that has been evaluated with the cross-linking of databases from the National System for Surveillance and also the National Program of HIV/AIDS in the country. This has been estimated that since the beginning of the COVID-19 epidemic in the country, the loss of follow-up has been reduced 2%. That's very, 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 very early data. At the moment of the outbreak, our cascade of care was having within the first column approximately 85% among those that are diagnosed, but within the second and the third column are the biggest challenges that we are still having in the country. First, the access to antiretroviral therapy still is between 70–72%, and the final column that is achieving the viral load is still really, really low, no higher than 50%. So that was actually influencing in the turnaround of laboratories and diagnosis that needs to be addressed in this time. The standard of care for severe cases in the country are recommending hydroxychloroquine and azithromycin, and among the worsening of those with clinical symptoms, the use of tocilizumab. Can you please continue the next one? So what's the government doing regarding the answer of the epidemic in the country? That emergency declaration was including a national financial assistance that is called FASA. There was a link with the Ministry of Work and Economy, and another program that's called as Quédate en Casa, prioritizing people with more than 60 years old, diabetes, cancer, and it was actually putting a very important point and interest among those with HIV/AIDS. Next, please. So what's the department and the national program for HIV/AIDS doing? Well, they were publishing a guidance on clinical management of HIV patients that was putting aspects on two specific type of populations: people with antiretroviral therapy and those that were newly diagnosed. The first one providing prescriptions for laboratory and refills, and providing multiple drug dispensing up to 3 and 6 months in certain situations among those that are achieving undetectable viral load, having a very good compliance on appointments, and also not missing any appointments in the last year. And for those that were newly diagnosed, only 1 month of therapy just to evaluate adverse events, and also using dolutegravir-based medications for them. Next, please. So what else is going in the country? Well, many programs that are PEPFAR funded, like FHI 360 and COIN, are following the national guidance and actually providing a support for people that are not actually attending the services, distributing the food packages and also other consumables. Has been evaluated the antiretroviral dispensing at home within the communities for those that are in high risk or that they are living in different regions of the country. Also, mental health has been provided in a remote assistance through academia and other NGOs. For example, UNIBE is providing contact for those that are requiring any mental health support. And also the government through the hotline that is 462 is providing information about coronavirus, but also transferring and referring cases that are requiring mental health assistance as well. Next, please. So what are the opportunities that we are having at this time? Well, one of the opportunities that we are having is that finally we are ramping up and potentializing the dispensing and facilitating the earlier and faster initiation and antiretroviral therapy with simplified medications like dolutegravir, for example. That was one of the goals in the country. And also diversifying the assistance that has been provided, historically speaking, for those that are living with HIV. One of the elements that we have observed is that people are really aware and really interested in coming back when they were lost by a couple of years, because they have heard that it's very important to have their immunological response restored in order to fight against COVID. So that's a beneficial aspect of having this, because it's producing actually an interest in revamping the intervention that has been done in HIV event. And also, one of the elements that can be considered is piloting for the first time HIV self-testing that is not actually part of our initiatives. Probably that's going to be discussed a little bit later, but that's a very good opportunity to see that. So what is the challenges that we have? Next, please. So the pending challenges is that one of the biggest problems so far since the beginning of the epidemic is that we don't have mechanism of doing viral load, HIV viral loads so far, because all of them are centralized in the National Reference Lab, and they are fully dedicated for COVID-19. So probably we're gonna have people on antiretroviral therapy that are really compliant. They are not having actually a way to confirm that they are undetectable. So that's one of the challenges that still we have. The second one is confidentiality. Confidentiality regarding people that are visiting others, the community label. Many people probably are not interested in having any disclosure to other people that are actually in quarantine as well. So we really want to help, but at the end of the day, we need to be aware that they are living with others and not necessarily are actually interested in disclosing their HIV status. We don't know yet the rates in the Dominican Republic exactly. So that's one of the surveillance challenges that we are still having. But it's going to be important in the future to observe how both pandemics are conflicting in the country. Community HIV testing among key populations, people that are not actually moving into the lab or the clinics for having an HIV test or screening testing, but also the migration of those that are moving back their homes. That is one of the important elements that has been observed in the Haitian community in the Dominican Republic. New PrEP enrollments has been also a big challenge. They are not self-perceived as having any disease. So they are not having sex with others probably, or maybe they are not considered at risk because self-risk perception is quite a big challenge among most of race populations for PrEP in the country. So new enrollments has been identified as a challenge. Mental health crisis and gender-based violence. We don't have a lot of data regarding gender-based violence so far, but has been observed a very high rate of anxiety, stigma, or self-perceived stigma that has been identified through the contacting of by phone for people calling to the emergency and hotline number, and also obviously when you are disclosing your HIV status, when you are procuring mental health assistance is another problem that you can have about that. Next, please. And I think that that's everything that I'm gonna share with you. There are some questions. I don't know if you are answering right now or we're gonna let them by the end of the webinar.
Yes, thank you. Thank you so much. I'll ask you, just like the other presenters, to actually hold on questions. We're going to go through all of the presentations first, and at the end, we'll have about a half hour for questions and answers. So thank you so much for sharing. I think, you know, seeing the expansion of multi-month dispensing, seeing the expansion of initiation with dolutegravir and optimization, seeing the addition of diversity of including food packages and consumables to the deliveries, seeing the opportunity to maybe start self-testing, which will help the community testing for KPs. And I think the real innovations you highlighted for mental health via remote assistance and a national assistance hotline are really amazing to hear about. So thank you very much. We'll move on to lessons from Ecuador. For Ecuador, we have Dr. Amira Hedwaza, who is an Ecuadorian medical doctor with 30 years experience in public health and bioethics. She is executive director of the NGO Corporación Quimarina and the largest civil society organization in Ecuador for HIV response and headquarters of the Coalition Plus platform for the HIV response in the region of the Americas. With that, over to you, Dr. Amira. Thank you so much for being here.
Thank you so much. I would like to thank the IAS for this invitation. It's very important for us from Ecuador to share our experience. So good morning here in America, good afternoon other parts of the world. I'm going to do a short presentation of the situation in Ecuador from the perspective of Kimirina. Kimirina is an organization that has been working for 20 years in Ecuador with communities affected by HIV epidemic. So next, please. In the context, I would like to share with you that development of the epidemic of COVID-19 has had a fast outbreak. The first case was identified on February 25th, and by April 11, we already had 7,858 cases. You can observe in the infographic on the top right that the growth rate is fast, and by April 18th, they were already 922 cases confirmed. In the data that I have today is 10,128 cases. We are on the 4th place in Latin America. That's very, very difficult. The capacity of the diagnosis is limited. You can see in the flag that approximately 25,000 tests have been carried out, but only 10,000 have not been processed yet. That are data of 11 April. There are several reasons for this situation, as you see. There is no organized information. The curves below are from the Ministry of Public Health. The infographic is from the National Emergency Operations Committee. The flag from another governmental institution in charge of communication management. The truth is that the country overall reacted slowly. The National Health Services and course management system rapidly collapsed. There hasn't been a good coordination between the national and local governmental levels. The social isolation hasn't been successful applied in the province of Guayas and Guayaquil, where is the more serious situation. 559 cases versus 38 in Pichincha, where Quito, the capital and the second most populated city, is in Ecuador. Mortality is not clear either. In the 11 April report, it was observed that there existed 369 persons whose deaths were due to COVID, and there were other 436 deaths under examination to know if they were caused by the new coronavirus. So our more challenge is about this information and the transparency of information. Next, please. You might be wondering why this situation puts a country of 17 million people in the 4th place in Latin America impacted by COVID-19. As you can see in the per 100,000 inhabitants, we are in the 1st place with 57 cases for 100,000 inhabitants. That's very severe situation. Well, the main causes are, besides the conditions of inequity and poverty that were very severely evidenced in Guayaquil, there was a lack of organization and leadership of the public powers. And also there's another explanation with the flow of people from Spain and Italy to Ecuador, where there are Ecuadorian migrant communities that increased during the Christmas holiday and the carnival season. As well as you see on the slide, it's also that Ecuadorian society has a family nucleus and caring for the elderly in the nucleus, in the familiar nucleus, which may be possibly increase the risk of spread to immediate family members. Also, Ecuador has a greater proportion of independent workers, taxi drivers, merchants, in-house help, etc., and contractors with little to no social nets. So the challenges of mobility restrictions have been very, very severe. Next, please. We have lessons learned that are a little painful. It was negligence to understand the severity of the epidemic produced and we had painful consequences as many health workers have died. There was a weak capacity of health system to provide measures of biosecurity, and there was lack of cooperation with civil society. The academic sector, the scientific societies, specialized NGOs, communities, profit private sector, etc., was not called or heard, so the consequences were very, very bad. In HIV response, where the civil society is very organized, there was some achievements. For example, the Ministry of Health decide and make some adaptations very quick to provide ARVs for 3-6 months, etc. But almost all prevention programs are in standby. There is also a big challenge because there is stock breaks, downs of ARVs that could be in the next very approximate future. The system of security of the social security has not enough ARVs, and the Ministry of Health is providing them, but all the country is having a lot of challenges about this big problem. So for us, civil society, we are challenging that situation, and we are very active on the demand to not allow this situation to happen. Also, I would like to share with you that the social isolation caused an humanitarian effect in KP, a very severe in transgender women, in sex workers, in people living with HIV, with severe social consequences. Next, please. In this slide, I present the situation on HIV in Ecuador. Once again, the focus of attention is Guayaquil and Guayas, with 46% of the problem, and we still have many challenges with the cascade. We still have 24% of people who do not know their diagnosis, and 21% of them who are not under treatment. In turn, 43% of the latter viral load is detected. We know that exists underreporting, and that mainly the key populations that are the farthest from the official system. They are not sufficiently included on the statistics. Next, please. In order to improve the response in Ecuador, it is neither ethical nor admissible that the health professionals at all levels do not have all the biosafety guarantees. Health workers must participate in the decisions and demand adequate work conditions. We also demand the public sector to work with civil society. We can support in the fields of diagnosis and in the linkage with the public system for their prevention and care. Work with civil society and communities has been proven successful in HIV. We can support screening and diagnosis by community trained personnel, as in rapid tests, also in tests in real time, PCR. We can support the linkage with the prevention program in coordination with the health services. I would like to share with you that before in the HIV response, before the civil society work, that were 80 days or 90 days to begin the treatment. As we begin to work with the public sector, there is at maximum on an average 6 days to begin the treatment. So we can support on active case finding and support the case isolation, the prophylaxis, the linkage of health services for treatment, etc. Next, please. Finally, it is necessary as a lesson learned not to let the most vulnerable people continue to die or become ill, including the most affected by HIV. In Ecuador case, these most affected people are sex workers, transgender women, who are now in a deep humanitarian emergency. There is a lot of violence, there is a lot of need of food, of the basic needs to live. We as Quimirina and Coalición Plus are supporting some of them, but it's far from enough. We provide mental health, remote assistance, support for food, etc. But it's really, really needed in a scenario where it's expected a decrease at least of 6% of the Ecuadorian GDP at the end of this year. It's mandatory to develop social protection programs for people living with HIV, LGBT communities, and people who do sexual work, among others. It is also mandatory to guarantee the provision of ARVs, prevention programs, and the continuation of the HIV response. Next, please. As in the 18th century, the affirmation of this hero of Ecuadorian medicine is valid nowadays, and the call of attention is for accountability and transparency in the information. Thank you for your attention.
Thank you so much for that presentation and sharing those lessons from Ecuador. I think everything from the unique challenges of holiday travel and independent workers, but also taking note of how prevention programs are on standby, and especially highlighting the impact, the humanitarian impact on members of key populations. Very important topics. Thank you also for highlighting this challenge for healthcare workers and the disproportionate deaths, and really in your recommendations, the need to include healthcare workers themselves in the decisions and the designs of the response. I think that mirrors what we know about Nothing About Us Without Us and community-led responses, and I think it holds true for the insights for healthcare workers as well. So thank you. With that, we are going to move over to lessons learned from Mexico. And we have Dr. Brenda Crabtree with us. Dr. Crabtree is a staff physician from the Infectious Disease Department at the National Institute of Health Sciences and Nutrition from Salvador Zubiran, and assistant professor of the HIV program at the National Autonomous University of Mexico, which is the only HIV program in the country. Over to you, Dr. Crabtree.
Good morning, everyone, and thank you to the IIS for inviting me and to the Educational Fund team to putting this fantastic webinar together. So I'm going to present our experience in our institution at the Instituto Nacional de Ciencias Médicas y Nutrición here in Mexico City. Next, please. So currently, as in April 19, the epidemic of COVID, it looks like this. We have around more than 8,000 COVID patients that have tested positive from almost 50,000 people tested. And as you can see, the most affected city is Mexico City here in the center. We are currently in the acceleration phase, as you can see here below. And the incidence of new cases is increasing every day. So we are far from flattening the curve. Next. So like in other parts of the world, a young population is really been affected. Actually, the average of age of the ones who have tested positive is younger than in other parts of the world, probably because we have a very high rate of overweight, obesity, diabetes, and hypertension at early years. But certainly, as you can see, in green are the ones who have better outcomes as compared to those who are with more age, in yellow, who have not have more severe disease. Like in other cohorts, male is most affected in compared to women. And it is important to say that we have not so lack of access of testing and limited infrastructure for or resources to do testing. So if you only count the mortality in those who have tested positive, the mortality rate is 8.3, which is pretty high. However, due to estimated and mathematical models, according to the registered positive cases, the estimated mortality is about 1.2. From those who have tested positive, 65% have been treated ambulatory, 10% hospitalized but stable, 20% severe with a severe disease, and 5% have required required intubation. Next, please. So the problem in our health system in Mexico City is that we are a huge, tremendous city with more than 20 million people living in this area. So if we have a positive, if we are being positive and only 20% of the population in our city gets infected, that means that more than 4 million will be affected by COVID. And of those, probably 220,000 people will be in need of an ICU bed in a very short period of time, around in 1 or 2 to 3 months. So for this, it's important to say, as many colleagues have mentioned, Latin America has around 1 to 4 beds per 1,000 persons. Mexico has 2.7, so that means that currently we have only 1,200 beds for ICU, and this will be extended because of the sanitary emergency to 5,000. However, that will be probably not enough. And also, human resources of specialists are also lacking. We have around 1,000 critical care specialists and 900 ID specialists. So when we compare this to Europe, Europe has for their population between 4 to 7 beds per 1,000 inhabitants. Next. So being our hospital a teaching tertiary hospital, it was natural that we were good candidates to become turned into a COVID only site. So in the first March, we started being a COVID site only. Next. So what happened is in our institute, we have a large HIV clinic who has more than 2,000 active patients. So in 3 weeks, we had the challenge to reach out to all of our patients as possible, to encourage them to come to pick up ARVs for 3 months. Normally, we give them 1 to 2 months. And we looked in our database and selected stable patients with undetectable viral load and CD4s above 200 to reschedule their clinical visits ahead of July. We made flyers with general information about COVID infection, and we put that in a web page and social media so they can inform them what to do, who to call, etc. And we also wrote guidelines for patients about COVID HIV, putting some recommendation about isolation, signs of alarm in order to go to the hospital, online mental health support, and also support in case of domestic violence, which unfortunately, since the lockdown, who has been for 4 to 5 weeks here in the country, has been increased tremendously, unfortunately. Next. So the major challenge for us has been what to do with those in need for hospitalization for non-COVID reasons, because we are a country in which we are a reference site in which we have normally between 5 to 20 hospitalized patients because of late diagnosis. We are a region and a country in which unfortunately, most of our diagnosis is still in the context of late diagnosis. So we desperately look for funders and donors to give us support. And a few weeks ago, we managed to have 20 beds in a private hospital for 2 of the institutes here in the area, and also for the Clínica Condesa, which might be not enough, but still very good to support of those in need for hospitalization. It is very far away, 16 kilometers from our site, but we will have a private transportation, and every day will going 4 of our healthcare workers from the 2 hospitals, and obviously the care is for free for patients, and ART viral load and CD4 cell counts will be provided by the HIV program. Next, please. So for up to now, of the overall almost 500 people who have been tested positive in our site, 5 of them are people living with HIV, and as you can see, all of them are with undetectable viral load, very young population, and most of them with integrase inhibitors-based regimen. One didn't require hospitalization. The other 4, 3 of them are already at home, and 1 is still on the ICU, very sick, and not all of them have comorbidities. However, most of them have been with a good clinical outcome. Next. So finally, this has been very tremendous challenge to turn out to become a COVID site. And I want to acknowledge the fantastic team of our HIV clinic, who has managed to do all what I have mentioned before. And of course, I want to thank the patients and the community, because they have been really comprehensive with all this process. And of course, I want to acknowledge all our fellows and all the physicians that are in the front lines here at our institution and all around the world. Thank you very much.
Thank you so much for the work you're doing and for sharing those experiences. Everything from the specific outreach to HIV clients for multi-month dispensing to information and ability to be reached virtually. Also, thank you for raising the distribution of your COVID cases. Younger population, but also the younger people with better outcomes, but the comorbidities of diabetes, obesity, hypertension, and wondering how that comes into play. And especially thank you for mentioning the increase in domestic violence that you're seeing during lockdown. I think this is a worldwide phenomena we are seeing. And I think together there are going to be opportunities on how we grapple with this, not just now, but going forward. With that, we will go ahead and move forward to lessons learned from the United States. And we are fortunate to have Professor Monica Gandhi with us today. She is Professor of Medicine and Associate Chief of the Division of HIV, Infectious Diseases, and Global Medicine at UCSF, University of California, San Francisco. She is also Director of the UCSF Center for AIDS Research, CFAR, some of my favorite institutions, and the Medical Director of the HIV Clinic Ward 86 at SF General Hospital. Her research focuses on HIV in women and adherence measurement in HIV treatment and prevention. Over to you, Dr. Gandhi.
Okay, thank you so much for having me with everyone else. I've really enjoyed the talks. So next slide, please. So the US became the epicenter of this pandemic on March 26 at 5 p.m. I remember it well. And this was after, starting in Asia, really high rates in Europe, but US has maintained this position now for this entire month, and we'll keep on doing this with at the rate we're going. Essentially, as of now, we have almost 800,000 cases. This is a huge number. The next case report in the entire country is 200,000 cases in Spain. So we are far and above the epicenter of the pandemic. This is out of 2.48 million cases worldwide. We're containing this much of the virus. And we've reported 42,518 deaths. As of April 11th, we have also become the country reporting the highest number of deaths. And you can see around the country that there are areas that are containing most of the virus. New York has been particularly infected. New York State itself has more infections than any other country in the world, more than Spain or any other country. So we are definitely the epicenter. Next slide, please. So in terms of the clinical characteristics of COVID-19 in the US, we have had some case reports out of Seattle for some critical care patients, but I think this was the most illustrative case report example. This was the first 400 cases in New York City that was reported in the New England Journal on the 17th of April. And out of the first 393 patients, there is this predominant male predominance, which is been observed in many, many settings, including the US, with lots of speculations about it. And in fact, it seems to be possibly related to smoking, possibly related to increased rates of congregation. It could be related to genetics. So that really seems to be coming out in all sorts of cohorts. The most prevalent risk factor, at least in this country or in the New York City case series for severe disease, was obesity, as defined by a body mass index of greater than 30. And though that had been observed in other settings, it was most stark in this US-based cohort. The symptoms of infection were cough and fever and shortness of breath, as has been common reported, lots of myalgias, fair amount, almost a quarter of diarrhea or other GI symptoms. And in this case, 90% lymphopenia, a quarter with low platelets, and many had elevated liver function tests and inflammatory markers. And of those who presented, a third were intubated, and only a third of those were eventually extubated. So 2/3 remain intubated or are in the dead category, which was 10% of the total cohort. And we already talked about obesity. So that seems to be emblematic of the epidemic in the US, in the sense that New York City is really the center of it. So next slide, please. So if we think about the impact of HIV on COVID, or the impact of COVID on HIV, I think that there are reasons to think that people living with HIV could have worse outcomes, and there are reasons to think that people living with HIV could have better outcomes with COVID. And this is exactly what needs to come out from all of these talks and these analyses as we start working together to put together our data. For one thing, if we just focus on why people with HIV could have worse outcomes with COVID, it has to do with the distancing from clinics. It has to do with not necessarily the virus, but with the public health response to the virus. Understandably, most countries, as you've described, have enforced social distancing, but part of social distancing is saying that people who have chronic illnesses should stay away from the medical care system. So this is the first time since 1918 that we're saying to people who have chronic illnesses, stay away from places that you could be exposed to the virus, which is clinical healthcare systems. And so we've suddenly moved in the space of a couple of weeks from talking about linkage and retention in care in HIV to keeping people away from the clinic. It's really unprecedented since we started HIV care. And in that setting, people not getting their antiretroviral refills, people not getting long enough durations of their antiretroviral refills, antiretroviral stockouts, people being scared to come to the clinic, not knowing if the clinic's open, all of these are going to have effects on people being able to maintain their medications. In addition, the question of sheltering in place and And social distancing has, as often described, is a privilege, is an ability with people who have homes, and in setting of epidemics of HIV in urban centers in the United States, where there is an overlap with homelessness, where there's an overlap with food insecurity, the idea that people can shelter in place and just stay home is a difficult one when there's no homes to be had. And so in the city of San Francisco, for example, we had a large outbreak, the largest outbreak reported in a shelter about 10 days ago, and we're still waiting to see the impact on those living with HIV. And then the other reasons to think that there could be worse outcomes with HIV, you know, it was first speculated that or more immunosuppression would, as with any infection, make things worse. We haven't seen that yet. And the other reason to think this is that all these comorbidities that have been described to make COVID worse, which is higher rates of hypertension, people who are older, people who have cardiovascular disease or respiratory disease, or diabetes. These are high prevalence comorbidities in people living with HIV. There's also the question that, and this has been speculated as well, could there be better outcomes with people who have HIV in this setting of the COVID pandemic? The reasons that have been brought out here, and these are speculations as well, is there really the worst effects of COVID seem to be this massive inflammatory response. This, you know, there are high viral loads in the nose and in the mouth early on in COVID, and that's what really causes it, SARS-CoV-2, to be so highly transmissible. And then SARS-CoV-2 goes down in the lungs, and at that point, a massive inflammatory storm or cytokine storm can occur. And if HIV modulates inflammation, then could there be less inflammation in the setting of and less of this massive storm and less ARDS with HIV? The second theory that's been brought out is the idea of some of the HIV medications having some effects on the RNA virus that is SARS-CoV-2. And this is, again, still speculation. We really need studies on this, but it does seem that the triphosphorylated form of tenofovir, which is of course the metabolite of both tenofovir alafenamide and tenofovir disoproxyl fumarate, does dock onto the SARS-CoV-2 RNA polymerase, just like the HIV polymerase is actually RNA dependent because our HIV is, of course, a retrovirus. The SARS-CoV-2 has an RNA polymerase as well. And could that effect of tenofovir actually possibly inhibiting SARS-CoV-2 polymerase have any effect on less susceptibility of those living with HIV on tenofovir to disease? We don't know that yet. There is a trial started on April 1st among healthcare workers in Spain to see if tenofovir disoproxyl fumarate and emtricitabine will prevent SARS-CoV-2 in those who are exposed, which are healthcare workers, but we don't know that yet. And then, of course, a lot has been made of at least these two protease inhibitors, specifically more lopinavir ritonavir, having activity against the SARS-CoV-2 protease in vitro, and that is also seen with the first SARS virus. You know, don't know yet. Again, one clinical trial published in the New England Journal with lopinavir ritonavir was pretty small, 200 patients, 100 in the lopinavir ritonavir group, 199 who weren't on lopinavir ritonavir, and didn't show, at least in that trial, efficacy of lopinavir ritonavir, though it was given a little bit later than probably people would now, 13 days median after people had come in with COVID. But again, we don't know this yet. So I think that there's reasons to speculate that things could be worse for those living with HIV, and there's reason to think that it could be better. And no matter what, the public health response, and this is from the New York Times, this publication yesterday, that the pandemic's hidden victims, sick or dying, but not from the virus, no matter what, as the coronavirus overwhelms the healthcare system, anyone with other illnesses and chronic illnesses are going to be at a disadvantage. And the longer that we stay closed, we have to think of creative ways to see our patients and to help our patients. Next slide. So in the city of San Francisco, we have been interestingly spared, and that's a very speculated question why we've been spared the more devastating effects of COVID than our the first most densely populated city in the United States, which is New York City. We are the second. What happened is community transmission was first reported in the city of San Francisco on March 5th. And what happened the next day is that all the major tech companies in San Francisco closed down, and they employ half the city. So Facebook and Twitter and Google and these other major tech companies that are housed in San Francisco or around San Francisco closed down. So even though the city put shelter-in-place guidelines on March 16th, there were things that had closed even prior to that. The day after community transmission was reported in San Francisco, we at our HIV clinic, which is called Ward 86, and we're the publicly funded HIV clinic in San Francisco, we put out guidance on changing in-person visits to telephone visits for our patients living with HIV. And that guidance was followed. Patients, even if it wasn't followed, patients did not want to come in. As soon as community transmission was reported, even though we're still open for business, the patients do not want to come in. We at our urgent care clinic have been empty. And so it isn't just guidance, it's that people are staying away from the healthcare system because they're frightened. And the other major impact of patients living with HIV is it's the same people who work on HIV and infectious diseases that are being pulled for the COVID response. So all these primary care providers who spent a lot of time thinking about their patients are out of clinic. And so I don't think it's just the telehealth and the distancing. I think it's that the very people who spend all their time on HIV are being pulled out logistically for the COVID response. And so we now have a second infectious disease team in the hospital called the COVID-19 ID team, and we start at 8:30 a.m. We have a multidisciplinary meeting with all the services in the hospital. We talk about every COVID patient in the hospital, possible treatment trials, and then we spend all day ruling others out. And so that surge ID team means that it's really the nurses and the social workers that are playing a huge role holding down the fort at Ward 86 and keeping patients on the telephone feeling supported. We have two projects that are trying to help people with HIV in our clinic. One is the outreach project, which means that we call them even if they don't come in. We have been circulating, and we have 2,500 patients, and we've been reaching out to them and calling them. And what we find out is that a lot of people don't have phones. And so we got a donation of phones, and now we have to figure out how to get them to patients, because the very point of people being lost to care and in telephone medicine is that you need to have a telephone. And then we also have a telehealth project where we're trying to enhance their telephone visits by calling them 2 days before, asking them to be in a quiet place, not in line at a food bank, for example, and just have all their medications available. And in this city, we also have a male predominance of infections, and we also have the predominant group being affected is Latino immigrants. And then next slide. The one thing that we are going to do on Thursday night, and there is in New York City town hall today, and emulating what's happening in New York, we are going to give a town hall. This is virtual, of course, and this will be at 6 to 8 p.m. this Thursday. And I will give a talk on COVID and living with HIV. And then we're going to have two other experts in the city talk about services in the city, which ones are closed, which ones you can get a hold of, how to get your insurance renewed, how to get 90 days antiretroviral refills. And we hope that people living with HIV, again, they have to have digital access. And that's one entire problem with trying to work with telehealth in the setting of poverty. But if they have telephone access and they have Zoom access, hopefully we'll be reaching some of our patients with HIV through this virtual town hall. And I'll stop there. Thank you.
Wow, thank you so much for sharing those experiences. I think everything from raising the question, what does it mean that for the first time we are encouraging healthcare seeking behavior not to seek, but to stay home? And what does that mean for the long term of how we've been trying to influence over the years healthcare seeking behavior? What does it mean to have a lot of the HIV leadership and expertise being the first port of call for much of the COVID leadership and expertise? And I think we are seeing that across the world. that in many cases, individuals who've been tapped to help lead the national response, in addition to the clinical responses or aspects of it, are coming from the HIV national and local leadership. So how is that helpful and how is that harmful? So thank you very much for sharing that. We're now going to go into, and we have a great amount of time for questions and answers. So we're going to go to the questions and answers from the forum first, and then we'll move on to some that were submitted ahead of time if that's possible. And I am going to, number one, thank all the presenters in advance. Thank IAS once again for this. And I'm going to hand it over to Dr. Lucy at IAS to moderate the questions and answers. Thank you.
Fantastic. Thank you so much, Shannon, for joining us today. And thank you very much. I'd like to echo Shannon's appreciation of all of the panelists. A couple of specific questions that have come in. The first one in relation to the Dominican Republic and a question around HIV self-testing. It's a question that's come in saying in their context, the time is to take self-testing to scale, but that's stalled because of COVID-19 and yet seems to be essential at the moment. Do you have any advice just in general for scaling up or enhancing access to HIV self-test during this time?
Well, there has been a long discussion in the country to start piloting self-testing, and that's actually a good discussion that just recently restarted as an opportunity to keep going on the first 90, that is keeping testing. So one of the ideas that the Department of HIV STIs is having is to identify the most at risk populations that are mostly in going directly to the communities through peer navigators and other NGOs and institutions that are working with the national response to start doing like general guidelines for self-testing. Recommendations exactly, we don't have like a specific step-by-step things to do, but definitely this is a very good moment to start that discussion. The governments will be probably interested in revamping that. That was actually one of the strategies that we used for MMD and dolutegravir treatment, that listen, this is a very good opportunity to provide medication for more than 3 to 6 months. So let's start it. So that's the beneficial side of the COVID-19 epidemic.
Thank you very much for that. If I can now direct the next question to Dr. Pillay from Brazil, and also if anyone else would like to jump in on this question. It's specifically in relation to PrEP, pre-exposure prophylaxis, and PEP, post-exposure prophylaxis, and to see if A, there's been any evidence of taking either of those things in a preventative capacity for COVID-19, and B, on the other side of things, how has COVID-19 affected access to these prevention measures for people to protect themselves from HIV at this time?
Hi, perfect. We are not being able to see any patients here that were taking PrEP with COVID-19 right now. We saw some patients with TDF-based regimen, people living with HIV, but not with PrEP. It's possible. Tenofovir has some activity in SARS-CoV-2 in at least as experimental data. But we are willing to see, to collect some data regarding the risk of PrEP, if there's a lower risk for PrEP users to have COVID-19. So regarding the PrEP availability, we are dealing with, we're struggling to provide for longer time the PrEP. And then we also have some video appointments just to ensure if the tests are still negative, And because people who were taking PrEP are usually the persons are usually healthy, so there's no major concern regarding their health apart from their HIV status. So we're just checking the HIV test, and then we'll be able to provide for a longer period the PrEP medications.
Fantastic, thank you. And if I could ask a follow-up question, it actually links to some of the discussion from the earlier session today, but could you describe any challenges you've seen, or any recommendations in terms of people who newly test for HIV, test HIV positive during COVID, in terms of their initiation onto treatment and sort of care options if they test positive for HIV during the pandemic?
Yeah, what we're doing regarding the patients who are stable HIV suppressed patients, we are just rescheduling their appointments for for another moment that we will maybe more peaceful moments. So, but the recently diagnosed patients and the patients who are not suppressed, we are trying to accelerate those appointments just to make them stable, just to start medications or to restart medications or to start some kind of salvage regimen, and then to have them becoming not vulnerable to infections, to HIV-related infections and HIV-related conditions. Because I think there's no wrong time to restart medications or to start medications, but this is really a bad time not to being on HIV medications, because the health systems are so overburdened and people are so worried about COVID-19 and so on, that you become sick with HIV, that it's quite a preventable disease. It's not a good idea.
Right, thank you very much. If I can build on that response and ask Dr. Paulino Ramirez from the Dominican Republic to expand a little bit. You mentioned in your presentation about 3 cases of people living with HIV who had fairly low CD4 or high viral load. The question that has come in is asking if there have been any examples of individuals who have stable or virally suppressed HIV and have also either died or experienced difficulties in relation to COVID-19.
So yes, that's one of the questions I had. The problem with the epi data that has been collected from positive COVID-19 cases is that there is no desegregation within nationality or HIV status, etc. It was only observed the testing and confirmation of HIV status when they were having severe symptoms for the purposes of the guidelines. The national guidelines, the Dominican national guidelines, are including screening for other viral infections, including HIV. And that's one of the questions regarding, well, are they informed that they are having HIV at that moment, or they are requested permission for doing so? Well, no, and I don't think that happened, because it's in a standard of management. So identifying or looking at the distribution of cases, positive COVID cases among the HIV population is still a question mark. Probably in the future, we can do some serological studies evaluating the presence of co-circulating antibodies and correlating the data with treatment and outcomes. But I don't think that that's one of the actually targets at this point of the national response.
Great, thank you very much. Would any of the other panelists like to add a comment on that question? Okay, I'll continue. For Dr. Gandhi, Monica, in the US, and specifically in your experience, a comment has come in commending the example you gave about giving mobile phones to patients to help them actively engage virtually with facilities. two questions related to that. One is, do you have any other examples of things that have worked well in terms of sharing food or welfare items to reach poorer people who are in need of additional sort of social services during the pandemic? And then secondly, how have you been able to get antiretroviral medication and other medication for comorbidities to people living with HIV if they are afraid to come into the facility?
Yeah, so two things have been happening in terms of antiretroviral refills. One is ADAP, which is our AIDS drug assistance program, which a lot of low-income people get their antiretrovirals from. This program didn't used to have 90 days of refills. And so we've, people living with HIV have lobbied ADAP to allow for 90 days of refills, which is, we're working on. So that will allow people to have a longer time. And then also commercial insurance companies have all changed over to 90 days refills. In terms of getting people phones and other items, one thing that we've really noticed is that our older patients, we had a special program for them called Golden Compass, where we would have people come in and socialize and have narrative groups and have wellness groups and brain health. And it was just very important for socialization and isolation. And we were really worried about people who are older living with HIV, who are already isolated, being so isolated in the face of social distancing. So we got a donation of these types of digital pads, and we met the patients in the garden that's outside of our clinic with masks and handed them these digital pads. We called them and said, could you come and we'll give you this kind of iPads. And then we've been having groups on these digital pads. So by Zoom, because we had to bridge that digital divide by giving people these items. We do have a large homeless program called the Pop-Up Program at the clinic, and these patients are still coming in. Ward 86 has always been a place where people just come in and congregate. And so the patients who are homeless are still coming in, and we encourage them to do so. And we have food every day for them, so that's kind of their way of getting food. Everyone masks at the door. And we are all masked as healthcare professionals, and we think that we absolutely are encouraging people that we want to see them.
Thank you. And a question that's just come in, still directed for you, would be to ask if there are any studies on viral interference as a factor that can reduce the COVID-19 risk for people living with HIV. Oh, sorry, Dr. Gandhi, I'm not sure you could hear my question.
I'm sorry. Could you ask the question one more time?
Yeah, let me repeat it. The question's just come in and it says, are there studies on viral interference as a factor that can reduce the COVID-19 risk for people living with HIV?
Viral interference, I'm not sure you mean with tenofovir? Or the two viruses colliding, and I guess I don't understand. If you could clarify the question.
Okay, I'll wait for the respondent to clarify in the comments.
Okay.
I'll come back to the question. Thanks.
Okay.
Maybe a question, if I could direct it now to Brenda from the Mexican experience, but again, please anyone do add to this if you have some suggestions. It's a question that's come in today, but also very much links to the discussion in the session earlier this morning, was if you were to give some advice about the human resource side and how to motivate healthcare workers and better support healthcare workers beyond providing adequate PPE, what advice would you have for facilities or even for ministries of health to best support the workforce during this difficult time?
So this is a tough question because all of us all of us in the health, as healthcare workers, have been experiencing anxiousness and probably fear because we have heard in previous experiences from other countries before us that many of the healthcare workers have been infected and many casualties also. So I guess the benefit of being later in the epidemic, in the pandemic, because we had 3 months at least for preparedness, although at some point you think this preparedness is never enough. But I would suggest that if I look back, I would say it would be good to assure PPE, properly equipment for prevention for the healthcare workers, so that everybody feels secure, because we had in the north of the country a clinic in which they were not prepared, and more than 20 healthcare workers and turned out to be COVID positive, with very unfavorable outcomes in a third of them. So I guess the encouragement is that really the decision makers and the government assure all the healthcare workers to have good equipment for protection, and that's the only way. However, we as physicians, I see my fellows, they have been really brave and committed to all this pandemic. So there are, if the governments commit to have a good equipment of protection, I think that's the best way to encourage them to see how their health really makes the change in the response to COVID-19.
Thank you very much. Monica, back to you. I see the question's been clarified, so if you'd like to have a go at the response.
Yeah, I don't think that viral interference is what's going on here. So what I mean by that is they are really totally two different types of viruses. One is an RNA virus, which is the SARS-CoV-2, gets in, gets out, doesn't stay around. That's why when you're cured of coronavirus, you're cured of coronavirus. Now the hope would be, of course, that we have long-lasting immunity, and that we don't know yet, and that's a whole question. But an IgG against SARS-CoV-2 probably means you have immunity for a while, whereas an IgG against HIV just means that you've been exposed and you actually have chronic infection. So then the idea of HIV, of course, is that's an RNA virus that converts into DNA and intercalates into your host cell chromosome. And so because they enter through such different pathways, and they have such different mechanisms of action, I don't think that they're colliding. I think, or helping each other, sort of out in any way. It is true that SARS-CoV-2 is the most deadly viral pandemic since HIV. We keep on saying that. And there will be, unfortunately, a point if we keep on going like this where we'll have to declare it the most deadly viral pandemic, but I hope that we can get in control of it before then.
Terrific, thank you very much. And one final question over to Ecuador, to Dr. Herdeuser, was just from your experience and your context, if you were to digest the most important recommendation that you would encourage others in other contexts to adopt based on your experiences, what would you say?
I could say that the possibility of coordination and to synergize all efforts is the most important thing to do. The citizenship and the government efforts must be put together. Otherwise, the chaos or the crisis could not be attended. So for me, it's very important that civil society could play a role of watchdog, but also to be very proactive to assure, for example, in my country, that all people living with HIV could continue with their medication. I think that's maybe very simple to say that, but in the reality, that's something that is very dangerous in the immediate future. Thank you.
Fantastic. Thank you very much. And thank you very much to all the panelists and for the excellent questions, but particularly for the panelists for sharing their wisdom and insights with us today. That brings us to the end of today's webinar. For more information on the presentation, please do visit the IAS website and the COVID-19 portal. The address is right there on your screen. And please do continue to send any ongoing questions via email to coronaquestions@iassociety.org. That portal is updated regularly in response to the questions coming in. So trying to be really a clearinghouse for the latest information. Yeah, thanks again to the terrific speakers, both this morning and this evening. And it is just so rich to learn from the very nuanced and context-specific examples and the innovations in strategies to respond in those very different contexts. I'd also like to thank the Swiss Agency for Development and Cooperation, SDC, and Merck Sharp and Dom, our sponsors, without whom this webinar and the whole series, in fact, would not be possible. And also just to let you know that your feedback is really important to us. And at the close of the webinar shortly, you'll be directed to a short evaluation survey. Please do complete it and share your recommendations for how the series could be improved going in the future. And do stay tuned. Our next webinar is coming up at the end of April that will have a focus on testing, both in terms of COVID-19 testing and HIV testing. So we look forward to seeing you then. Stay safe and enjoy the rest of your day.